So the study is a randomized phase 3 trial that compares combination immunotherapy to combination BRAF MEK targeted therapy in the front line, and if patients exhibit progression and met eligibility criteria, they could cross over to the alternative trial. So the DREAMseq trial was taking treatment-naive patients with metastatic BRAF mutant melanoma, stratifying them by performance status and LDH, and randomizing them to those two sequences. And because we thought the curves might actually cross, we chose 2-year overall survival as the primary endpoint. The study started in 2015, and in 2021, with 59% of patients having crossed the 2-year time point, the Data Safety Monitoring Committee recommended closing the trial because of a clinically meaningful 20% difference in 2-year overall survival, favoring the immunotherapy first sequence, with 72% of patients being alive at 2 years with immunotherapy first and 52% with targeted therapy. This data was presented at the inaugural ASCO virtual plenary session in 2021. We followed the patients to 5 years in this study, and at ASCO I am presenting the 5-year follow-up clinical data. And what we saw was a sustained benefit in terms of overall survival out to 5 years, with now a 30% absolute difference in overall survival for the immunotherapy first sequence, 60% of patients alive versus 30%. We also saw a 3-fold improvement in 5-year PFS and a continued increase in duration of response, favoring immunotherapy over targeted therapy. We then looked at the various subsets in the trial: age, sex, performance status, LDH levels, and a marker of good performance status, which are the patients who do best with targeted therapy. And in every group, the 4-year PFS was significantly better for the immunotherapy arm. And in almost all of those groups, the 4-year overall survival was significantly better for the immunotherapy first sequence. We then looked at incidence of CNS metastases, and we saw that there were double the number of CNS metastases as first site of relapse on the targeted therapy arm compared to the immunotherapy arm, indicating that immunotherapy was working better in the CNS. And the patients who had CNS relapse, by and large, didn't cross over and did very poorly. We then looked at the response rates and saw similar 51% response rates between the first-line immunotherapy and first-line targeted therapy. And we were surprised a little bit that the response rate wasn't higher for targeted therapy, because it was higher in the registrational trials. And so we wanted to see what was the cause of the lower response rate. And we saw that if we looked at 12 weeks, there were many more responses on the targeted therapy than the immunotherapy. But by the time we got out to 24 weeks, 41% of those responses had progressed, and so they could not be confirmed, while for immunotherapy, only about 16% of the responses couldn't be confirmed, illustrating the better durability of benefit if you respond to immune therapy. So in summary, this long-term follow-up further supports the value of giving immunotherapy first for patients with treatment-naive metastatic BRAF mutant melanoma. And the reason why it was beneficial was better duration of response, and fewer CNS relapses. And this applied to practically every subgroup. And so I think it's now clear that for most patients who have BRAF mutant metastatic melanoma, they should be receiving combination immunotherapy first. I would add that we have the tissue and the blood from these patients, and we're looking at biomarkers in the tumor and the blood for two things: to see if we can identify a population that should get targeted therapy first, and a population who gets immunotherapy first, who is progressing early and should be switched to targeted therapy earlier. And that work is ongoing, and I hope to present that in the next year.